I take a GLP medication myself. I want to be upfront about that before I share a study involving 217,000 women because this topic is personal for me. Recently, researchers at the University of Pennsylvania found that women taking these medications were diagnosed with breast cancer about 30% less often than those who were not. That statistic spread quickly online. So today, I want to take a closer look at what the researchers actually did, how they addressed possible explanations, and the real limits of this finding. This episode is for education, not medical advice. I am a health coach, not your doctor. Stick with me because how this study was designed is key to understanding it. So let me begin with my own experience because it explains why this study matters to me. I had a hysterectomy that left one ovary. For 11 years after, I did not use hormone replacement therapy, nor was I offered it. During menopause, I gained 45 pounds, and I want to be clear about this. I did not change my diet or stop being active. I followed the advice I give other women, but my weight still went up. This is not about blame. It is about metabolism. Losing estrogen during menopause changes how the body stores fat and manages blood sugar. For many women, this leads to weight gain and higher blood glucose levels, even without changes in habits. During this time, my BMI went over 30 and I developed type 2 diabetes. No doctor ever explained to me the reason my blood sugar, weight, cholesterol, triglycerides, LDL, and blood pressure were creeping up. Dr. Mary Claire Haber has coined this as the metabolic syndrome of menopause, and having 3 of these factors was associated with higher risk of heart disease, stroke, type 2 diabetes, and even cognitive decline. So I began taking a GLP medication, Tirzepatide, first to manage diabetes and then for the weight that would not budge otherwise. That is my perspective on this study. When I see research suggesting these drugs may lower breast cancer risk, I do not see it as just an observer. I am a woman in my late 40s to early 60s with a family history of neurodegeneration and cancer who pays close attention to her lab results. Here is the citation said plainly so you can look it up. Elizabeth McDonald and colleagues, GLP-1 agonists are associated with a significant reduction in breast cancer incidence in women, and it was presented at the 2026 American Society of Clinical Oncology annual meeting, abstract 10506, and published in JCO Oncology Practice in June 2026. Dr. McDonald is a breast radiologist at Penn's Abramson Cancer Center. The first thing to know is what kind of study this was because that shapes what we can learn from it. This was not a clinical trial. No one was randomly given a drug or placebo. Instead, the researchers looked at electronic health records. This type of study, called a retrospective cohort study, can show a link but cannot prove cause and effect on its own. The researchers started with 217,025 patients who had breast imaging. That is the 217,000 number you may have seen. Then they focused on women aged 45 to 80 with a BMI of 25 or higher and clear imaging results. This narrowed the group to 94,827 women. The big number is just the starting point. The actual study group is smaller and more specific, which matters because the results apply to women similar to many of my listeners. In this group, about 2.4% of women were diagnosed with breast cancer, and around 16% had been prescribed a GLP-1 receptor agonist before their imaging. Of those who took the medication, 1.65% developed breast cancer. This is the part I really want to explain because it is where the science either builds trust or loses it. The main challenge with a study like this is that women who take GLP-1 are different from those who do not, even before starting the medication. They may have different weights, ages, diabetes statuses, and each of those factors affects breast cancer risk. If you do not account for these differences, you cannot know if the medication made a difference or if you are just comparing 2 very different groups. The researchers addressed this using a method called propensity score matching, and here's what that means in simple terms. A propensity score is the number that estimates how likely a woman is to be prescribed a GLP-1 based on her profile. The model considers age, BMI, breast density, race, ethnicity, and type 2 diabetes status and combine them into a single score for each woman. Next, the researchers paired women. Each woman who took the drug was matched with a woman who did not, but had a very similar score. This created 2 groups that looked almost identical on paper, same age, weight, diabetes status, and breast density. The goal was to make the medication the main difference between the groups. Remember those 6 factors because they can be misleading if not considered. A higher BMI increases breast cancer risk after menopause. Dense breast tissue raises both the risk and the chance of something showing up on imaging. Diabetes brings insulin resistance, which is also linked to tumor growth. By matching on these factors, the researchers sought to control their influence so they could focus on the drug's effect. Now, here's the main result, and then I will break it down honestly. Women who took GLP-1 were about 30% less likely to be diagnosed with breast cancer. That number spread widely online, and it is a real finding from the study. But look at what happened after the researchers matched the group. Before matching, the difference seemed even larger. After making the groups more similar, the benefit decreased, but it was still there. This does not mean the study failed. It means the method worked. Some of the original difference was not due to the medication, but to the groups being different from the start. The number that remains after matching is the one I trust, even though it is smaller. There is one more thing I want to explain because it shows the difference between a headline and the real story. Sometimes a change sounds bigger than it actually is. 30% fewer sounds huge, but in real terms, this study found about 7 fewer breast cancers per 1,000 women. That is a real drop, but it is also modest. Both are true, and you should know both before deciding how important this is. So keeping 2 numbers in mind, a meaningful drop in relative terms and a small one in absolute terms. Both are accurate. They are just different ways to describe the same result. The authors admitted they don't know the exact mechanism, and I respect that honesty. What we can do is explain why the results make sense rather than being a fluke. There are 3 possible pathways to consider. The first pathway involves estrogen, and I want to make this as clear as possible because it can get pretty confusing. Think of estrogen as an umbrella term for 3 different hormones your body makes at different life stages. Estradiol is the strongest type, kind of like your body's main estrogen during your younger and middle years, and it mostly comes from the ovaries. Estriol is the gentlest, and it goes up a lot during pregnancy, almost like a special purpose estrogen for that time. Then comes estrone, which is the main estrogen after menopause. You can picture estrone as the backup supply that takes over after the ovaries slow down. So after menopause, most estrone is produced in fat tissue with the help of the enzyme aromatase, which converts the other hormones into estrone. The more body fat a woman has after menopause, the more estrone her body makes. And this matters because estrone can send growth signals to certain types of breast cancer cells, helping them to multiply. In simple terms, more fat means more estrone, and more estrone can feed some breast cancers. The link between weight, fat tissue, and estrogen is clear in medical research, as shown by studies in the International Journal of Molecular Sciences in 2025 and other journals. So if a medication helps reduce fat tissue, it may also lower estrone production, which is the connection researchers are focusing on in this pathway. Now, I want to be very clear. Everything I just explained about the estrogen your body makes naturally in fat tissue, not about hormone therapy. The estradiol used in modern hormone therapy is different from fat-made estrone, and the estradiol has its own anti-inflammatory effects. The link between hormone therapy and breast cancer is a big topic, and the evidence is not the same for everyone. For women who have had hysterectomy, the Women's Health Initiative estrogen alone trial actually found a lower rate of breast cancer. So if you're considering hormone therapy, that is a discussion for you and your doctor with your full history in mind. Please do not leave this episode afraid of estradiol. The second pathway involves insulin. It goes beyond just weight. GLP-1 medications lower insulin levels and improve the body's response to insulin. High insulin levels are called mitogenic by scientists, meaning they encourage cells to grow through specific pathways. Lowering insulin reduces this growth signal. For someone like me who started this medication for diabetes, this pathway is very real, and it is why I was prescribed the drug. The third pathway is inflammation. Excess fat tissue increases leptin, lowers adiponectin, and increases inflammatory signals such as IL-6 and TNF-alpha. This combination can help tumors grow. GLP-1 medications help shift this balance back towards protection. The same research explains this in detail. Now, the big question, and the one raised by many on social media, is whether GLP-1 medications lower breast cancer risk even without the weight loss. In this study, the researchers matched women for BMI, so both groups had similar body weights, yet they still saw an association between the medication and lower cancer rates. This finding suggests that other factors may be at play beyond weight loss. However, this is an observation, not proof, and it highlights the need for further research. So I want to be clear about this uncertainty because keeping the facts straight is a core value of mine. Now, Tirzepatide is not just a GLP-1 medication that I take. It is a dual agonist, meaning it activates both the GLP-1 receptor and the GIP receptor. The McDonald's study looked at GLP-1 receptor agonists as a group. Dual agonists like Tirzepatide share the GLP-1 effect, but they are not identical, and the study does not address whether breast cancer finding applies to the dual agonist. I am sharing this because it is easy to assume the study applies directly to my prescription, but it does not, at least not yet. I take this medication for diabetes and a past BMI of over 30 with my doctor's guidance, not for cancer prevention. My A1C is now a 5.0 and my BMI is 24, which is healthy. If future research shows a benefit for dual agonist, I will share it. For now, I keep these ideas separate. You listen to this show for the details most posts leave out, so here they are. The study is observational, meaning it shows a link, but not a cause and effect relationship. I want to be clear about the main limitations so you know what this result truly means. The study only shows association. Because women were not randomly assigned to different treatments, we cannot know if the medication itself caused the lower risk. For example, another factor such as lifestyle may explain the results. The follow-up period was short. Breast cancer can take years to develop, so some cases may not have appeared yet. This means the actual effect might differ over a longer period. Surveillance bias is possible. Women prescribed GLP-1 medications may visit their doctors more often and could be screened differently, which might affect the number of cases found. Healthy user bias matters. People who take medications regularly often engage in other healthy behaviors that are hard to measure, and this may influence their overall risk. Propensity score matching helps balance known factors, but cannot handle differences that the researchers did not record or account for. Understanding these limitations is important. Good observational research is just the start. Dr. McDonald and her team are now building a multi-site clinical trial to test directly whether GLP-1 medications can lower breast cancer incidence in women at high risk, including women with a prior history of the disease. That is the correct response to a strong observational signal, not celebration or dismissal, but a better study. So what does this mean for a woman listening and thinking about her own health? It means you have a question to discuss with your doctor, not an answer to act on from a podcast. If you already take one of these medications for diabetes or weight, this study is a reason to be cautiously interested, but not to change anything. If you are not taking one, this is not a prescription. It is just a promising sign in a field that is still developing. Now, to help you start the conversation, here are a few questions you might want to ask your own healthcare provider. Based on my personal risk factors, would a GLP-1 medication make sense for me? Does the research about breast cancer and GLP-1 medications apply to people in my situation? Are there any risks or side effects I should be aware of? If I am not eligible for these medications, what other steps can I take to reduce my risk? Bringing questions like these to your doctor can help you make choices that are right for your health. Now, what I hope you take from this episode is not just information about the drug, but about the method. When you see a number like 30%, ask yourself three things. What kind of study was it? What did they control for and how? And what does that number mean in absolute terms, not just in relative ones? These questions will help you cut through the noise. Track your health, measure your progress, make improvements where you can. I will keep tracking my own numbers and share what I learn. This is Kristen Beasley with the Healthy Life Approach podcast. Take care of your beautiful brain. Disclaimer, I am a certified health coach, not a physician. This episode is educational, not medical advice. If you are experiencing any of these symptoms, please consult a licensed healthcare professional for proper evaluation and personalized treatment. Please consult your licensed provider about medical concerns and before starting any supplements, medications, protocols, or lifestyle changes. This podcast does not create a coach-client relationship. Individual results may vary. From time to time, episodes and materials may include affiliate links that may provide a small commission at no extra cost to you. Thank you for being here.